the most important in diabetic patients is they have the atherosclerotic component of progression is much faster. So they develop the disease in a faster way than do people that have non-diabetic. That's why the incidence of cardiovascular complication is from 2 to 4 times higher in diabetic patients as compared to non-diabetic. So the consequences of developing atherosclerosis turns up to the complication of the disease, which is this superimposition of the thrombi on top of the atherosclerotic lesion, which is called atherothrombosis. And this also occurs because the thrombotic component of diabetic mellitus patients is enhanced as compared to non-diabetic patients. As such, platelets are more reactive to attach and adhere between them, so hyperreactive because they express more adhesion molecules. They are more sensitive to different stimuli, to secrete agonists such as thromboxane, ADP, or whatever, and all the signaling pathways also that trigger platelet activation are more susceptible to get activated. This is about platelets. In addition, this inflammatory condition that accompanies or is behind the diabetic mellitus state also contributes, not only because it helps or aids in the progression of atherosclerotic disease, but also it contributes to that prothrombotic environment, such as the presence of C-reactive protein, which has been thought to somehow contribute to thrombus deposition or growth, the presence of that's called microparticles or microvesicles, which also contribute to thrombus. And so all this together, in addition to a hypercoagulable state. And this is important because this presence of this inflammatory milieu, what it does is it induces the liver to enhance the transcription of coagulation factors. So we have factor 7, tissue factor, which are found to be enhanced. Fibrinogen, which is inflammatory mediator, but also plays a key role in the synthesis or the production of thrombin, which is the ultimate product of the coagulation cascade. So we have an enhanced coagulation on top of hyperreactive platelets. And unfortunately, this is accompanied by a decrease in the fibrinolytic system. Because if the clot was formed and the fibrinolytic system worked perfectly well, there would be a balance, but this is not the case. Because in the diabetic patient, all the fibrinolytic proteins or components are found to be diminished, and all the inhibitors of the fibrinolytic system are found to be enhanced. So we can see here that this is what makes a difference or more a more risky situation in diabetic patients compared to non-diabetic. And I forgot to mention one important point, which is the role of the vascular endothelium layer. Because the endothelium in healthy conditions has a very important, plays a key role in balancing all this prothrombotic, antithrombotic environment. But in diabetic patients, the exposure of this continuous exposure to free fatty acids, because there is lipolysis going on, in addition to this inflammatory milieu, and the increase in insulin resistance or hyperglycemia, what occurs is that this endothelial layer gets damaged and gets dysfunctional. So all the protective properties associated to the endothelium are lost. So you can see that there's a vast array that covers from the endothelium to the atherosclerotic development to thrombus formation, which are found to be impaired or enhanced. That's a very important point because we have just defined which is the enhanced risk in the diabetic mellitus patients, which makes quite one couldn't think that aspirin has definitely been on board. But I must say that there is non-official guidelines on the use in primary prevention, but there is a continuous advocate to the use if you have a high risk. If you are a kind of patient who perhaps is older than 50 years old, have more than one cardiovascular risk factor and is susceptible to suffer an event, definitely I would suggest that the intake of aspirin would overcome all bleeding risks associated, potential bleeding risk associated. So that should be probably advocated, and the physicians community was taken into account. The ESC guideline and also the American Diabetology Association suggests that it's a physician's choice and a personal choice, but if there is some cardiovascular risk factors on board and on top you are old, that could be considered.